You can continue, Dr. Frisk.
Thank you. Thank you for that kind introduction, Dr. Hewitt. Good evening, everyone. I hope I'm audible and my slides are visible.
Yes, it is.
Okay, great. So I would like to welcome all of you to today's session. Just give me a minute to just sort out some technology here. Okay. Good evening, everyone. Again, apologies for that delay. So today we will be discussing ambulatory care for children with diabetes. This is basically for patients who are being managed or followed up in the outpatient setting. So this is the outline of my talk. So we're going to look at components of care for patients with diabetes. We're going to look at insulin therapy in brief, because this was already addressed last week by Dr. Legong. We'll look at blood glucose testing. We'll look at dietary advice and monitoring of glycemic control. And finally, we'll look at quality of care indicators and growth monitoring. So in terms of components of care, there are four main components that we are looking at in terms of the services that we are offering to these children. And the first thing we need to look at is the structure. And this is in terms of organization of the services and finances. And you know, finances impact on various aspects of service delivery, including availability of supplies such as drugs, availability of staff who are qualified, and various other aspects. And then the second component is the processes. And in terms of processes, we want to encourage positive messaging. We also want to set expectations early enough, as soon as the diagnosis is made, so that we avoid the situation whereby we have patients being influenced by different information that is not accurate, and things like myths and like that. And then also the psychosocial support is very important. And then the third component is the content of the service that we're providing. And this is in terms of the education we're providing and also the treatments that they're receiving. And finally, also the outcomes, which you're going to look at in detail. So in terms of structure of care, it's important that the care is structured towards achieving certain goals. So it means that the service provider must have their goals in mind, okay? So that they structure their care to be able to achieve those goals. And then we also want to ensure that we provide an individualized treatment, form of treatment for all these patients with diabetes. And then thirdly, access to multidisciplinary diabetes expertise is a key component in terms of the structure of care for these patients. So what are the goals of care? So the first, of course, is that we want to provide a high quality of life for these patients. So a diagnosis of diabetes should not change that. They should be able to still achieve their potential, achieve their goals and dreams despite that diagnosis. And then we also want to ensure that they continue to have normal growth and development. The psychosocial aspect is very important, given that this is a chronic condition. So definitely they're going to go through a lot, even in terms of accepting the diagnosis, and even the amount of information we are giving them regarding the diagnosis, the interaction with society, in school. So all this can have a psychosocial impact on these children. So we need to ensure that they are well adapted. And then we also want to detect comorbidities that are associated with type 1 diabetes. And these are mainly the autoimmune conditions, and we'll look at that later on. And we also want to avoid the acute and chronic complications of diabetes. So when we are managing children and youth with type 1 diabetes, we recommend that we use a person-centered pediatric diabetes care model, where the young person with type 1 diabetes and their family is at the center. And then we have a multidisciplinary team of experts who are supporting this person and their family. So in terms of the multidisciplinary team, depending on where the setting is. So if you're in a setting where you don't have an endocrinologist, for example, then the primary healthcare provider, who could be a pediatrician, will definitely be a member of that multidisciplinary team. We also need to have pediatric diabetes specialists, such as diabetes educators, nutritionists. We also need to have psychologists and social workers on board. And also the support at school is very important. We've had situations whereby children are rejected in various schools before they eventually settle on a particular school just because they have a diagnosis of diabetes and the school or the teachers are afraid. So all these aspects are very important. And of note is that all these specialists should actually have an interest or should have had some training in pediatrics and should have also had some training in diabetes. So what are the aims of individualized diabetes care? So the first, of course, is to ensure that we have ongoing diabetes education. Okay, so this should occur at every visit or any time that we come into contact with the patient. We need to continually advise them on insulin management, glucose and ketone monitoring where that is available. Of course, monitoring for comorbidities and risk factors for complications, as well as monitoring for the complications themselves. And then we need to consistently articulate the goals, okay, especially the glycemic goals or their glycemic targets. And then as much as possible, we also need to link them up with support groups, okay? So these are other patients or other families who have diabetes. So this really helps in them adjusting to the condition, and they also get to know that they're not alone. They're not the only ones who have type 1 diabetes, and they can also get to share experiences. And then, of course, psychosocial screening is very important, and this should be done regularly. And whenever psychosocial issues are identified, then they should be referred appropriately to a specialist. So we also, during our routine clinic visits, we need to address the intercurrent health problems that they may have, which may not necessarily be related to diabetes, so such as infections, okay? And then at every visit, we need to review all the medications and supplements they're taking. Remember that they may also be taking herbal supplements. So it's always good to just inquire and try and find out if they're taking other medications, and then try and find out how could these medications interact with the treatment that you're recommending for them. And then, of course, advise them accordingly. Then I've already mentioned assessment for autoimmune comorbidities. Assessment for disordered eating behaviors is very important. Remember that food or diet is a key component of diabetes management. And with that actually increases the risk for disordered eating behaviors, especially for for adolescents and young adults. So you may find that they're really like restricting the carbohydrates they're taking, or even skipping meals, yeah? So it's really crucial to look out for this, because this can also cause impaired growth and as well as other issues. Then, of course, it's important to assess their development, their education, how are they doing in school, How is the support at the school level? Is the school and their peers, are they aware about the diagnosis, and how do they know how to intervene in case of an emergency? Then are they also engaging in other extracurricular activities like leisure, sports, and also just look at their psychosocial status. So during these reviews, physical examination is key, just like for any other pediatric patient. So we always need to check their height, their weight, monitor their BMI and pubertal status, keeping in mind that diabetes, poorly controlled diabetes can affect their growth, okay? It can also cause delayed puberty. Then, of course, it's important to monitor their blood pressure. And I know this is a challenge for many of us, but this is really critical because one, we know that hypertension can be a risk factor for progression of diabetes-related complications. And secondly, it can actually be one of the signs that this patient has developed complications such as chronic kidney disease. So we need to monitor their blood pressure at every visit. We also need to examine their oral mucosa, dentition. Because of the high sugars, they tend to have a lot of high salivary glucose, which increases their risk for development of cavities, as well as gingivitis. Then, of course, examination of thyroid for goiter, because they can also get autoimmune thyroiditis, abdominal exam for hepatomegaly. Children who have poorly controlled diabetes tend to get hepatomegaly because of increased glucose deposition in the liver. And this causes a condition we call Moriak syndrome. So they're usually stunted, poorly controlled, and they have a hepatomegaly due to a fatty liver. Then, of course, examination of the foot for any complications and neurological function tests. Skin examination is very important because we know the insulin injection can cause complications, especially if it's not done correctly, so they can get lipodystrophy. We also need to look for acanthosis nigricans, which may be associated with type 2 diabetes, as well as hirsutism and acne, which may be associated with the polycystic ovary syndrome. So having looked at that, let's look at insulin therapy. And this is going to be an interactive session. So I'm going to request that we have a poll question. The poll is anonymous. Nelson, kindly launch the poll question. So just sending your answers. We'll have just 1 minute to respond to this. Thank you. So the question says, which of the following statements regarding premixed insulin in type 1 diabetes is false? So A, premixed insulin can be delivered via continuous subcutaneous insulin infusion. Okay, I can see the responses are coming in. All right, I think we can close the poll. Let's see the results. So 36% say that premixed insulin cannot be delivered by subcutaneous continuous insulin infusion. That is an insulin pump, and that is correct. That is a false answer. So the definition of premixed insulin is correct. And patients who have type 1 diabetes should instead have, they should be given the individual components of insulin rather than the premixed insulin. And this is important because when you have premixed insulin, so it's a combination of regular insulin and intermediate insulin. So whenever you need to make adjustments, it doesn't allow for flexibility. So for example, if a patient has high blood sugars after breakfast, okay, and you want to adjust the short-acting insulin, the regular insulin, if you make that adjustment, then it means you're also going to adjust the intermediate acting insulin, which will increase the risk for hypoglycemia late in the afternoon. But when you have the individual components, then you're able to just adjust the regular insulin alone. So premixed insulin actually increases the risk for hyperglycemia and hypoglycemia. And it's basically in children, they are less effective, and they're not recommended for pediatric patients. So we recommend that we give them the individual insulins rather than giving a premixed insulin. Okay, so in terms of choice of insulin, this as much as possible should be individualized to give as physiologic insulin profile as possible. And insulin therapy was discussed last week, so I will not go into much detail about that, but basically we just remember that every time you take a meal, there's an amount of insulin that's produced in your body. And that is what we try to mimic when you're giving the multiple dose insulin, okay? So we give regular insulin before meals or rapid acting insulin before meals, and then we give a basal insulin that is present throughout. So storage of insulin is very important, and I think this was addressed. When you're giving insulin, it's also important that you are aware of which syringes you're using. So if you're using the 100-unit syringes, that should be used for the 100-unit insulin vial. If you're using the 40-unit syringes, use that with the 40-unit insulin vial. And then we also recommend, especially for pediatrics, that you use the small syringes with half or 1 unit per mark. And this allows us to deliver smaller doses of insulin. We're able to dose in half units. Then in terms of the length of the insulin needle, okay? For children and even for adults, the recommendation is to use the 4 to 6 millimeter needles, the smallest needles, okay? Because this is associated with less pain. And also when you use the longer needles, you're more likely to inject the insulin intramuscularly rather than subcutaneously. So compliance with treatment regimen, again, is key to success. So this slide just shows the devices for insulin injection. So we can have the vials and the insulin syringe, which of course the patient has to withdraw and then administer the insulin. Or you can have the option of insulin pen, which of course is more costly. So it depends on what the patient can afford. And here we're just seeing how the insulin is supposed to be drawn up. So ideally, you're supposed to withdraw an equal amount of air into the syringe as the insulin you want to withdraw. Then you push in the syringe into the vial, push out the air, and then withdraw the insulin that you require. So I think we can launch the next poll question, Nelson. You can look at this image, and then we have the question. So here we have a child with type 1 diabetes who was noted to have multiple abscesses on both thighs at the injection sites, and he was found to be reusing the same needle tip for 3 weeks at a time. Some abscesses were incised and drained, and he was put on antibiotics. What advice would you give this patient? So should the injection sites always be cleaned and disinfected? Should they continue to give insulin injections in the thighs? Pen needles can be used for 1 week. Use the 2-finger pinch technique when injecting. So we can end the poll and see the answers. So 68% says the injection sites should always be cleaned and disinfected. And 38% say we should use the 2-finger pinch technique when injecting. So the answer here, so with regard to disinfection of the injection site, so normally as long as the patient is observing basic hygiene, like they at least take a bath every day, we don't recommend that they have to, disinfect with an alcohol swab. But of course, if the patient is at risk, like a patient who has a history of abscesses, then we would recommend that. But that is not routine. Of course, we will not recommend that they continue to give injections in the thighs. This patient has lipohypertrophy, and this happens when there's repeated injection on the same site. So when we're going to look at in the next few slides on how we're supposed to rotate the injection sites. So whenever a patient has lipohypertrophy, then it's advisable that they avoid using that site. Sometimes we need to leave it for even several months so that it can recover before they can start using the site again. Because if they continue to use it, what happens, it's painless. So you'll find that the patient prefers that site, but the insulin absorption is impaired, and such a patient will likely have poorly controlled sugars. Now, with regards to reuse of pen needles, so it's not recommended that they be reused, because when they're reused, they become blunt, and then it becomes more painful, and then of course it increases the risk of infection. However, we know that this is a resource-limited setting. So if they really have to reuse them, then we usually advise that they should not reuse the needle more than 4 times. So after using it 4 times, then they discard and replace it with another needle. So definitely not for 1 week. And then actually the answer here is they should use the 2-finger pinch technique when injecting. So we can just look at the technique of injection. So the insulin should be given subcutaneously. And usually when you're giving, it's recommended that you pinch up some skin and quickly insert the needle at 90 degrees angle. And that is one of the reasons we're recommending the short needles, because it allows you to give the insulin safely into the subcutaneous tissue at 90 degrees angle. Then the skin should remain pinched, okay, to avoid the insulin going into the muscle. And then the plunger is pushed down all the way. After pushing the plunger, the patient should not remove the needle immediately. They should hold the syringe and needle in place for 15 seconds to allow for insulin absorption. And then they can let go of the pinch skin and remove the needle from the skin. So if they see blood or clear fluids where the needle went on, they can press the area for 10 seconds, but we do not recommend any rubbing of the area. So this just shows that demonstrates the 90 degrees angle for insulin administration. So these are the sites of injection. I think also this was mentioned last week, but just to remind us that you can inject around on the abdomen, keeping 2 centimeters away from the navel. And then you can inject on the front and the side of the thigh, also on the upper and outer arm, and the upper and outer buttocks, and also again on the behind the side of the thigh at the back. So in terms of rotation of injection sites, how are we supposed to rotate the injection sites? So ideally, you're supposed to choose an area. The patient is supposed to choose an area of injection. So for example, if you have the abdomen, you can divide it into quadrants. And then we can take quadrant 1, for example. So we can use this quadrant 1 for 1 week, okay? Ensuring that we are keeping at least 1 centimeter away from the previous injection, okay? So after 1 week, they move on to another quadrant. So they can move to quadrant 2. Then after another week, they move to quadrant 3. And so by the time they're coming back to quadrant 1, we have had enough time for that area to rest, so that we don't have we reduce the risk of development of lipohypertrophy. And the same can be done for the thighs and the arms. You can inject on one quadrant of the arm for a week and then move on to another one a week later. So this is very important. So we do not recommend that the patient, for example, injects the arm in the morning, then in the afternoon they go to the abdomen, then in the evening they go to the thigh. But they should restrict to 1 quadrant per week. The other thing I would like to mention is on the use of the thighs. We usually recommend that they use the thighs in the evenings or when they're going to sleep, because when they're active, like during the day or they're exercising, that can also cause erratic insulin absorption. So let's look at let's look at blood glucose testing. So blood glucose levels are affected by several factors, including, of course, the pattern of eating, the level of activity, and then, of course, illness. So, for example, if a patient has fever, they're likely to get hyperglycemic because there's increased insulin resistance. If they have gastroenteritis or they have an illness that's causing them to feed poorly, they're likely to get hypoglycemia. And then, of course, the insulin regimen and doses can also affect the blood glucose level. So it's important to remind the patients that the blood glucose information that they're providing, it's supposed to help the patient and family learn, and it's not being done for the staff. This is very important because many times you'll find that some patients actually falsify their records because they do not want to record abnormal readings, or they're only recording the good reading, what they consider the good readings, okay, on the diary. And then when we look at the glucometer, we have these high readings, these lows that they're not recording. And this is because they fear that maybe they'll be reprimanded because their sugars are not well controlled. So it's important that we always remind them that this information is actually supposed to help them and the family learn, and it's not being done for the staff. So in terms of interpretation of the blood glucose readings, so this is very important. I know it was mentioned last week, but I just want to remind us about this. How do we interpret the timing, the test with regards to the timing? So if the fasting blood glucose level basically is a reflection of the basal insulin. So if your fasting blood glucose levels are high, for example, then it's probably advisable to adjust your basal insulin, your long-acting insulin, or intermediate-acting insulin, like NPH, for example, if it's being given in the evening. And then the after breakfast level of sugar is a reflection of the dose of rapid or short-acting insulin, which is given at breakfast. The after lunch level usually is a reflection of the dose of rapid or short-acting insulin that's given at lunchtime or before lunch. And then the after supper blood glucose level tells us about the dose of rapid or short-acting insulin that's given at supper time. Now, the pre-lunch level gives us information about, one, the dose of insulin that was given at breakfast, that is the short or rapid acting insulin, or the effect of the mid-morning snack, okay? Or the effect of the morning long-acting insulin. And then the pre-supper level tells us about the dose of insulin that was given at lunchtime, that is the short or rapid acting insulin, the effect of the mid-afternoon snack, and the morning long-acting insulin. And of course, all the levels are affected by snacks and exercise. So when you're interpreting these readings, usually like it's good to look at a trend. For example, if you have a diary and you have readings for like the last 10 days, then you're looking at all the fasting sugars for the last 10 days. So you want to see what proportion of those are within target or that are not within target. So normally if you have more than 50% of the readings not within target, then you need to make an adjustment. So if your fasting glucose levels, for example, more than 50% are not within target, then it means you need to adjust your evening dose of the long-acting insulin. If, for example, let's look at the pre-supper level, there's a trend, more than 50% are high, then you need to ask yourself, is it because the dose of insulin at lunchtime is not adequate? Or is it, what snack are they taking in the afternoon? And could that be the reason why they're having high sugars just before dinner? Or is it the effect of the long-acting insulin that's being given in the morning? So this applies for a patient who is on NPH in the morning and in the evening. And interpretation of blood glucose readings is also only helpful when you have also records of foods, okay? So we normally recommend that the patient keeps a diary that includes the blood glucose levels, the insulin they're administering, and the food that they're taking. This is very helpful because, for example, if a patient had a hypo 3 weeks ago, okay, if they did not record the food or whatever activity that took place, then it will be very, very difficult to determine what could have caused that hypo. But when it's documented, you're able to tell, the trends, like are there some foods when they take, they're tending to get hypos or hypers. If they did some exercise or some sports, then you're able to tell, oh, this is likely to be the cause of the hypoglycemia they had. So let's remember that the records should always include the food and the activity that they're involved in. So let's look at the correction factor. So what is correction factor? This is also called the insulin sensitivity factor. And basically, this just tells us how much each unit of insulin will lower the blood glucose by in millimoles per liter. So 1 unit of insulin, by how much will it lower the blood glucose level in an individual patient? Okay, so we have a formula for calculating this. And now the formula depends on which type of insulin the patient is on. So if they're on a rapid acting insulin, so rapid acting insulin, remember, is like Lispro, Aspart, or the brand names use Novorapid, Humalog. So if they're using those ones, then we use a constant of 100. So you divide 100 by the total daily dose of insulin, okay? And the total daily dose of insulin includes all the insulin they are taking, the long-acting and the short-acting or rapid-acting. So when you divide 100 by the total daily dose of insulin, that gives you what the correction factor is. So for example, if my total daily dose of insulin was 20, my correction factor would be 100 divided by 20, which gives 4. So it would be 1 to 4, which means each unit of insulin will lower the blood glucose level by 4. Now, for patients who are using regular insulin, the constant we use is 83 and not 100. So we divide 83 by the total daily dose of insulin. Now, why is this important? It's important because when a patient has high blood sugars, okay, it means you need to give them extra insulin to correct for the high blood sugars. Because whatever dose that they're normally giving. So for example, if a patient is usually on 5 units, if they're using a fixed dose regimen and they're on 5 units of regular insulin at lunchtime, okay, that is supposed to take care of the food that they're going to take, okay? So this assumes that the sugar is going to be within the target range of 4 to 10. However, if their sugar before lunch is 15, then that 4 units is not going to be adequate. So you need to give extra insulin to bring that sugar down to the recommended target level. And that is where the correction factor comes in. So it tells you how much extra insulin you need to give these patients so that their sugars will be within target after the meal. So we can launch the next poll question. Okay, so a 10-year-old boy is on regular insulin. Well, people are even already answering before we finish the question. Anyway, a 10-year-old boy is on regular insulin, 3 units pre-breakfast, 3 units pre-lunch, and 3 units pre-dinner. And they're also on NPH, 6 units in the morning and 3 units in the evening. His blood glucose before lunch is 16 millimoles per liter. So which of the following statements is true? The correction factor is 1 to 5, that is A. B says the correction factor is 1 to 6. C, he should give 6 units of regular insulin before lunch. And D says he should give 4 units of regular insulin before lunch. Okay, I think we can end the poll. Okay. So 32% say the correction factor is 1 to 6. And 26% say it's 1 to 5. So let's see. So this patient is on regular insulin, okay? Remember we said if the patient is on regular insulin, we use a constant of 83 to calculate the correction factor. So what is the total daily dose of insulin this patient is getting? So they're on regular insulin 3 times a day, 3 units 3 times a day, so that's 9 units. And they're on NPH 6 units and 3 units, so that's 9. So that's a total of 18 units. So to calculate the correction factor, we divide 83 by 18, and that gives us 1.46. So normally you round it to the nearest whole number. So if it's 1.46, then it means our correction factor is 1 to 5. And that means that each unit of insulin will lower the blood glucose by 5 millimoles per liter. So now this, the patient's blood glucose level at just before lunch is 16 millimoles per liter. So how much insulin are we going to give? Remember that their normal fixed dose for the meal is 3 units, but you need to give extra insulin. So when you say the correction factor is 1 to 5, and our target range of glucose is 4 to 10, it means when the glucose is between 11 and 15, we need to give an extra unit of regular insulin. If it's between 16 and 20, we need to give an extra 2 units of regular insulin. So for this particular patient, with a glucose of 16, we would give 2 extra units of regular insulin. So they would give a total insulin dose of 5 units. Okay, so the correct answer there is A. And then we would give an extra 5, we'd give, sorry, a total of 5 units of insulin before lunch for this patient. Okay. So in terms of patterns of testing, so what is recommended? So this depends on many factors. Of course, we know blood glucose strips are very expensive, okay? So depending on the availability of testing strips, we would recommend different patterns of testing. So for a patient who has access to adequate strips, then the recommendation is they test like about 7 times a day. So that would be pre-meal, so pre-breakfast, pre-lunch, and pre-dinner, and then 2 hours post-meal. So 2 hours post-breakfast, 2 hours post-lunch, and 2 hours post-dinner, and at bedtime. However, in our setting, many patients do not have access to this. So like in Kenyatta Hospital, most of the patients test 4 times a day, usually pre-meals and at bedtime. We also have the option of doing 3 tests per day, okay? We call it structured testing, whereby, for example, you change the selected meal they're testing around every week. So for example, this week, we can say that we are testing pre-breakfast, pre-lunch, and post-dinner, okay? Then next week, they change and they will test post-breakfast, post-lunch, and maybe at bedtime. So by the time the patient comes to see you, like if they come to see you after a month, for example, with that structured testing, you're able to tell what is happening around different meals, and you're able to adjust make insulin or any other adjustments appropriately. And then, of course, whenever there are symptoms of hypoglycemia, the patient needs to test, and we will have a session on hypoglycemia in one of the future webinars. And then, of course, whenever the patient requires a top-up dose of insulin for extra food, or whenever they're ill, like if they have a fever and they're having high sugars or ketones, then they need to test more frequently. So basically, the patterns of testing are determined by availability of strips, as I've already mentioned, which of course is determined by other factors such as cost. It's also determined by the insulin regimen, the level of glycemic control. So a patient who has poor glycemic control, in a patient who has poor glycemic control, you might want to test more frequently so that you're able to make better adjustments to their therapy. And then, of course, patient factors will also determine the pattern of testing. Again, remember that you've said that we always need records of food and insulin for these blood glucose readings to be valuable. Kindly launch the next question. So which of the following should not be recommended regarding general diabetes care? A, all normal vaccines. So the question is, which one should not be recommended? A, all normal vaccines should be received. B, discourage child from playing actively due to the risk of hypoglycemia and poor healing when they get injuries. And then C, they should eat normal balanced food as cooked for all family members and as per hunger. So which is not recommended? Okay, we can end the question, the poll. Okay, so 56% say B is not recommended. So all patients with diabetes should receive all normal vaccines, okay? There is no contraindication for a patient with diabetes for vaccination, okay? And then secondly, the statement that says discourage the child from playing actively due to the risk of hypoglycemia and poor healing of injuries, that is not recommended. We know exercise is very important in improving the blood glucose control. Exercise improves insulin sensitivity. And also we want the children to live a normal life, just like other children. So we just need to empower them, okay, on how they manage, how to manage exercise and diabetes. And we're going to have a session on that. So all children with diabetes should engage in sports, normal sports like other children in school. The issue of poor healing, that should not even be an issue if they're well controlled, and it's not usually a common concern in children with type 1 diabetes. It's probably a greater concern with patients with type 2 diabetes. And then children should eat normal balanced food as cooked for all family members and as per hunger. That is true. So children with the type 1 diabetes should not be told to take a diabetic diet, okay? And with that, let's just look briefly at nutritional management. So I want to emphasize that there's no such thing as a diabetic diet for a child with diabetes, okay? Let's not tell our children with diabetes to take brown rice, to take brown bread, brown ugali, brown everything, and restrict carbohydrates for them. That is not healthy. Remember, these children are growing, okay? And they need the carbohydrates for growth. So if you over-restrict their carbs, then they are going to get stunted and they're going to get malnourished as well. So they need to have a healthy diet. And normally we recommend that the diet is actually a family affair. So you're not going to advise, make specific advice for this child with diabetes while the rest of the family members are eating unhealthy food. So it needs to be embraced as for the whole family. If you're not taking sugar, then the whole family is not taking sugar. Then there should be no sugar in that house, okay? So that they also don't feel like they're different or like they're left out. And also when we don't involve the whole family, this encourages disordered eating behavior, and also, it encourages them to start, like sneaking foods, or stealing foods, and basically that results in poor glycemic control. So it's important to consider the amounts and proportions that they're taking, which should be appropriate for age and growth. The carbohydrate content of the food should be matched with the insulin regimen. It's important to understand how to match the insulin with the food, and we need to educate the patients as well. And of course, all this is best done with the assistance of a dietitian. So you need to have a dietitian in your team. So during the review, the clinic review, we always need to, it's important to take a thorough dietary history at the time of diagnosis. So they need to have a food diary, okay? And then this needs to be reviewed regularly during each clinic visit, which should be ideally every 3 months. And we should recommend the correct food, of course, the correct amount, and feeding at the correct times. Avoid skipping of meals, okay? And then also review their food in terms also of in relation to their activities and their insulin regimen. So we're going to have a session on nutrition next week, and we shall have more discussion on that. So let's look at monitoring of glycemic management. Can you launch the next poll? Please launch the next poll question. Nelson, kindly launch the next poll. So regarding blood glucose targets, which of the following statements is not correct? It's not correct. Huh? So there's little scientific evidence for age-related glucose targets. When assessing glycemic control, 90% of blood glucose should be in the target range of 4 to 10. Each child should have their targets individually determined with the goal of achieving a value as close as possible to their physiological range. And hypoglycemia and awareness in a patient should be considered when setting targets for individuals. Okay, we can end the poll. So 53% say there's that it is not correct. It is not correct that there's little scientific evidence for age-related glucose target. So actually it is true. There is little scientific evidence for age-related glucose targets, and we are going to look at the targets in the next slides and the recommendations for that. When assessing glycemic control, just like I mentioned, when we were looking at how to make what insulin affects what blood glucose level, what insulin does, normally recommend that at least 50 to 70% of the blood glucose should be in the target range of 4 to 10. So 90% may not be realistic. So that one is not correct. And of course, each child should have their targets individually determined, okay? And the hypoglycemia and awareness should be considered. So hypoglycemia and awareness basically means that the patient has hypoglycemia, but they don't have symptoms, which is very dangerous, yeah, because that increases the risk of severe hypoglycemia. So in such patients, you want to adjust the targets upwards, yeah. Instead of 4 to 10, maybe you'd want to increase the target to 5 to 10 to reduce the risk of severe hypoglycemia. Okay, so these are the recommended glycemic targets, and I would like us to focus on 2 areas. These are the finger stick glucose measurements. This is what most of our patients measure using the glucose strips and glucometers. So the recommended glycemic targets are 4 to 10 millimoles per liter with a fasting target of 4 to 8. So this is for children based on the current ISPAD guidelines. And then for hemoglobin A1C, the recommended target for a child with diabetes is between 6 and 7%. And this target is recommended for all patients, regardless of their age. Kindly launch the next question. Please launch the next poll question. Sorry, we had a small technical hitch, but the poll question is there. So which of the following statements regarding glycemic control and hemoglobin A1C is true? A, HbA1c reflects the preceding 1 to 12 weeks, including the most recent preceding week. B, HbA1c of 8% is acceptable for a toddler. C, fructosamine and HbA1c reflect similar duration of glycemic control. D, HbA1c should be done at a minimum rate of 4 times a year. And E, microvascular and macrovascular complications can be predicted by daily self-monitoring of blood glucose. So which is true? We can end the poll. Okay. So 50% say HbA1c reflects the preceding 1 to 12 weeks, including the most recent preceding week. So that is actually not true. So hemoglobin A1c reflects the preceding 3 weeks, the preceding 3 months, but not the most recent preceding week, because the glycation in the preceding 1 week is usually reversible. Then after that, it becomes irreversible. HbA1c of 8% is acceptable for a toddler. We have said that the target is 7%, 6 to 7% for all patients. Fructosamine actually reflects glycemic control within the previous 1 month. So it is not true that they reflect a similar duration of glycemic control. It's true that HbA1c should be done at a minimum rate of 4 times a year, which is every 3 months. So that is actually the correct answer. Microvascular and macrovascular complications can be predicted by daily self-monitoring of blood glucose. That is not true. They're actually predicted by HbA1c, okay, rather than the finger stick measurements. So what is hemoglobin A1c, or glycated hemoglobin? So red blood cells normally contain hemoglobin, okay, and the blood glucose usually sticks to the hemoglobin, forming the hemoglobin A1c. So this is a slow and irreversible process, except within the immediate preceding week, where we said it's usually reversible, yeah. But after that, it becomes irreversible, and it essentially reflects the average blood glucose over the previous 3 months. So this means when you have a high blood glucose, you are going to have an increased hemoglobin A1C. The normal range is usually below 6.5%. This is for a person who does not have diabetes. But for those who have diabetes, we said our target is 6 to 7%. So what is the significance of HbA1c? So there's a large trial. There's a large trial that was done called the DCC trial many years ago, where they were comparing patients with diabetes who had tight glycemic control versus a second group who were on conventional therapy. And we're looking at the long-term microvascular complications. That's nephropathy, neuropathy, and retinopathy. And this study actually found that those patients who had tight glycemic control had significantly lower risk of long-term microvascular complications. So glycated hemoglobin correlates with the risk of long-term complications. And whenever you see a rising HbA1c, then that requires that action is taken. Can you launch the next question? So the following actions are recommended when there is discordance between HbA1c and blood glucose log, except, so blood glucose log is basically the blood's glucose readings on a diary or on a machine if they're using one. So what action would you take if there's a discordance between the two? So a check meter memory, psychological assessment on the assumption that the blood glucose values are falsified. B, clinical examination, including pubertal assessment and inspection of injection sites. C, check insulin handling. D, check TSH, transglutaminase, and cortisol. And E, suspect chronic renal failure. Okay, we can end the poll. Okay. So when there's a discordance between the HbA1c and blood glucose log, so what does this mean? So sometimes you have patients who, for example, a patient who has come for review and their HbA1c is 14, and when you look at their blood glucose records, they are, near perfect, okay? And that should, you should ask yourself how is that possible? And normally we recommend that you actually look at the glucometer, if they're using a glucometer, first of all, to just verify that what is recorded in the diary is matching with what is on the meter memory, okay? And many times, especially with the adolescents, you may find that actually there's a discordance, okay? What is there is not what is on the meter. And of course, when you find such a situation, then you need to ask yourself why would they falsify the information? And psychological assessment is very important in such situations. Then of course, clinical examination, including pubertal assessment. Remember, we said that patients who have poor glycemic control are likely to have delayed puberty. Then of course, inspection of injection sites. We said that if the patient has lipodystrophy or lipohypertrophy, that will affect the insulin absorption and will increase the risk of hyperglycemia or poorly controlled sugars. We need to check insulin handling as well and the storage of the insulin, because that could affect the blood glucose levels. And then for patients with diabetes, there are certain autoimmune conditions that increase their risk of getting hypoglycemic episodes. So if you have a patient with diabetes who's getting frequent hypoglycemic episodes, then we need to look out for other autoimmune conditions such as hypothyroidism, celiac disease, and adrenal insufficiency. So suspecting chronic renal failure, that is not the correct answer. That's not the first thing you're going to think about when you have a discordance between the HbA1c and the blood glucose log. Okay. So this chart just tells us basically about glycated hemoglobin. So if you have your patient in this green area, this is where we want our patients to be, okay? We've said between 6 and 7, okay? So if they're falling in the yellow category or even in the red category, then we need to start seeing how we can assist them to improve their glycemic control. Now, studies have shown that, like I already mentioned, that better HbA1c control is associated with reductions in long-term health complications. Now, it's been found that for every 1% drop in the glycated hemoglobin, we have a reduction of 43% in the risk for lower extremity amputation or peripheral vascular disease. It's also associated with a 37% reduction in the risk for microvascular disease, a 19% reduction in the risk for cataract, and a 16% reduction for heart failure. And this tells us just how significant a 1% drop in HbA1c is in terms of reducing the long-term complications. So let's look at screening for and management of comorbidities and complications. Kindly launch the next poll. Okay, thank you. So regarding long-term monitoring, which of the following statements is not true? So A, review of diabetes self-care should be done regularly. B, HbA1c, TSH, transglutaminase, microalbuminuria, and lipids should be tested every 3 months. C, clinical examination, including anthropometry, should be done every 3 months. D, injection technique, blood glucose testing technique, and psychological assessment must be done regularly. So which one is not true? Okay, we can end the poll. Okay, so 50% say that it is not true that clinical examination, including anthropometry, should be done every 3 months. Okay, so review of diabetes self-care should be done regularly. That is true. Okay, so we need to make sure that the patients are, we keep educating them, okay, on all the various aspects of diabetes self-care. We've talked about glucose monitoring, insulin injection technique, okay, nutrition and diet. So this is something that should be done regularly. HbA1c, TSH, transglutaminase, microalbuminuria, and lipids should be tested every 3 months. That is not true, and we're going to look at that in the next slide. Clinical examination, including anthropometry, should be done every 3 months. That is actually correct, okay, or at every visit. And it's recommended that these patients are seen at least every 3 months. And then, of course, injection technique, blood glucose testing technique, psychological assessment, these should be done regularly. So let's look at the screening and prevention guidelines for patients with diabetes, for children with diabetes. So in terms of glycemic control, in terms of glycemic control, we look at we evaluate 2 parameters. That's the hemoglobin A1c and the blood glucose readings, okay? So of course, the hemoglobin A1c should be done quarterly. That is at least 4 times in a year, okay? And for the blood glucose readings, this one should be evaluated during every clinic visit. For cardiovascular risk factors, so we look at several parameters. We look at the blood pressure, which we said should be taken at every visit. We also need to assess for the smoking status, especially for the older children, the adolescents, and the young adults. And we should discourage smoking in those who are not smoking and encourage smoking cessation in those who do. Then for lipids, we need to do a lipid profile for patients from the age of 11 years, okay? This is for all patients with diabetes from the age of 11 years. And if the lipid profile is normal, then it's recommended that this is repeated every 3 years. So this is for type 1 diabetes. For type 2 diabetes, then usually the screening is supposed to occur soon after diagnosis. And this is because by the time they are diagnosed, usually they have already started developing complications. Now, in terms of evaluation for microvascular complications, so for kidney disease, we use urine albumin creatinine ratio and urea and creatinine for screening for kidney disease. And for retinopathy, the patient should undergo a dilated eye examination or fundal photography. And then for neuropathy, they need to have a comprehensive foot examination. And all these should start at puberty or from the age of 11 years, whichever is earlier. This is after they've had diabetes for at least 2 to 5 years. And then it should be repeated annually for kidney disease and neuropathy, and every 2 to 3 years for retinopathy. For type 2 diabetes, like I already said, screening should start at diagnosis. And then with regards to autoimmune screening, so I already mentioned about thyroid disease, celiac, and Addison's disease. So thyroid function should be done, and if possible, antibodies. This should be done at diagnosis for children with type 1 diabetes, and then should be assessed every 2 years, okay? Or if they have symptoms, then you can assess them more frequently. For celiac disease, usually we screen using the tissue transglutaminase IgA, okay? Again, this should be screened for at diagnosis and then repeated every 2 to 5 years. But this can be done sooner if they have symptoms or they have a first-degree relative with celiac disease. For Addison's disease or adrenal insufficiency and other autoimmune conditions listed there, this evaluation should be done as clinically indicated. Psychosocial screening is very important. The diagnosis of diabetes is not an easy one. And of course, we've talked about the different dynamics that, can influence the psychosocial status of these patients, such as school, family, and even just the fact that they have to do all this, the frequency of testing, the insulin injections, okay? We can have issues with disordered eating because of, we have to be more keen on the diet. So it's important that these patients are screened shortly after diagnosis and then at least once a year. And there are several tools that can be used for screening these patients. And then in terms of anticipatory guidance for young girls of childbearing age, it's important to counsel them, provide preconception counseling, and advise them to make sure that their pregnancies are planned, because we know about the risks of complications for both the baby and the mother who has poorly controlled diabetes. And then, of course, discussion about risk-taking behaviors and also preparation for transition to adult care should begin early in adolescence. So with that in mind, so what are the indicators that we can use to determine whether we are providing the appropriate care for this patient based on the recommended guidelines? So we have patient indicators and we have clinic indicators. Okay, so for patient indicators, we want to look at the growth. Okay, how is the height for this patient? Are they growing? How is the height, growth velocity? How is the weight? Are they losing weight? If they're losing weight, like I mentioned earlier, that's a sign of a poorly controlled diabetes. Okay, puberty. Have they achieved puberty at the correct age, or is there delayed puberty? Then we also look at acute complications. So for individual patients, like how many times have they had to be admitted for DKA? Because admissions for DKA are an indicator of poor glycemic control. And also, what is the frequency of severe hypoglycemia? Because again, that is an indicator of poor glycemic control. Then in terms of social adjustments, we need to look at the schooling environment. How is their performance in school and how is the support system there? Also look at employment for the older ones. What challenges are they able to get to get employment, not be discriminated against because of their diagnosis? And then also we look at the number of clinic visits in the last 12 months. Are patients skipping their appointments, or are they skipping their appointments? Because we said they should be seen at least every 3 months. So if you have patients who are getting lost to follow up, then that's something that needs to be addressed. And I've already mentioned about the number of hospitalizations in the last 12 months for each patient. Are they missing school days due to diabetes? How is the food security? That is very important, because if you're going to tell them to take insulin 3 times a day and they don't have meals, then how is it going to work? Okay, so these are things that we really need to address. And then, has there been interruption in insulin therapy in the last 12 months? So those are patient indicators, and then we have clinic indicators. So for clinic indicators, these are the parameters you can use to determine whether your facility is providing appropriate care or providing the recommended services for children with diabetes. So in terms of prevalence, what are the numbers of children in your clinic? And for ISPAD, the ISPAD guidelines actually recommend that for you to be considered a center of excellence, you need to be seeing at least 150 patients, or have at least 150 patients enrolled. So if you have such a number, a large number, then already you qualify to be considered a center of excellence. And it means that you really need to work to improve the quality of care that you're giving. And in terms of acute complications, you also want to see what proportion of your patients are getting frequent hypoglycemia, what proportion of patients are below 5 years are getting severe hypoglycemia. Supplies are very important. So as a facility, are we having interruptions in insulin supplies or therapy? Okay. And then in terms of screening and prevention of microvascular complications, what percentage of patients being attended to in your clinic are actually being tested for proteinuria? What % are being tested for HbA1c? What percentage of patients that actually have their blood pressure taken during their clinic appointments? And what percentage of patients have their lipid profiles being done at the recommended times? So these are indicators that you can use to determine how you're performing as a center that provides care for children with diabetes. So it's important to measure regularly the progress of diabetes, okay? And these basic patient indicators should be measured at every visit if possible. I've talked about measurement of growth, which is a very good indicator of the quality of care. And remember that each visit is an opportunity for repeated information and education for patients. So finally, I'm just going to mention briefly about monitoring growth in childhood. We'll have a session on this. But just to remind us that growth follows a predictable pattern over time, and it can be affected by diabetes. So if the patient is getting insufficient insulin, this can result in stunting, and even if the blood glucose seem to be fine. Okay, so if you have a patient with diabetes who is stunted, then most likely they're not getting insulin, or they're not getting adequate insulin. On the other hand, if you have a patient with type 2 diabetes, then remember that being overweight contributes to the risk of diabetes. And also patients with type 1 diabetes can actually also be overweight, okay? And especially if you have patients who are on very high doses of insulin, that increases their risk of weight gain. And if they become overweight, then again, that increases insulin resistance. So growth is, monitoring growth in both these categories of patients is very important. So in terms of measurements, as I already mentioned, you measure the height, weight, and BMI at each clinic visit, and once every 3 months. If not possible, at least twice a year. The growth measurements should be recorded in a growth chart. So it's not enough to just take the measurements, but we need to plot it on a growth chart and then observe the trends, okay? When you're taking the height, remember to take the height without the shoes so that you get accurate measurements. And for children who are under 2 years of age, we need to take their length when they're recumbent, and the weight should be measured to the nearest 0.1 kilogram if possible. So we've said that you need to plot the measurements on a growth chart. You can use any growth chart that's available to you. So we recommend either CDC growth charts or the WHO growth charts. And remember that we have chart specific for boys and chart specific for girls and for different ages. And we have growth charts for height, for weight, and for BMI as well. So, and finally, I just want to make a comment on monogenic diabetes in terms of care for these patients and treatment. So just to remind us that there's some certain types of monogenic diabetes that can actually benefit from oral hypoglycemic therapy or the sulfonylureas. And we commonly use glibenclamide. And there are some mutations like glucokinase deficient mutation where they actually do not even require therapy because they tend to have mild hyperglycemia. And then for other mutations, they actually require insulin. So the most important point I want us to take from this is that we should never, any child who presents with diabetes has type 1 diabetes until proved otherwise, because 90% of children with diabetes have type 1 diabetes. We have seen cases of children being started on oral hypoglycemic agents, children with diabetes, yeah? So all children with diabetes should be started on insulin therapy, okay? Until proved otherwise by a pediatric endocrinologist. So if you have doubts about the diagnosis of type 1 diabetes, start the patient on insulin therapy, refer them to a pediatric endocrinologist who will investigate further to establish whether it is a different type of diabetes, and then they will initiate the other treatment if necessary. So I would like to just acknowledge SP e-learning website for the vignettes, where I borrowed some vignettes. Thank you very much, and I will be happy to take questions.
Thank you, Dr. Priska, for that great presentation. It was very extensive and very informative. We have used most of the time, and there are some questions that have been mentioned by the participants. Thank you for the participants for also participating in the poll. So since we don't have a lot of time, most of the participants actually asked to review the correction factor. They are not clear on the correction factor. So let's start with that one. Thank you.
All right. Let me just share that slide. So correction factor is, like I mentioned, is also called insulin sensitivity factor. A minute, let me just go to that slide. Yeah, so basically what it means, correction factor is basically how much each unit of insulin will lower your blood glucose by, okay? So like I mentioned, why do we need to know the correction factor? Why does every patient with diabetes need to know their correction factor? Because we have to educate them. From the time you make that diagnosis, from the time you transition a patient from DKA management, you need to tell them about the correction factor. And usually we recommend that you even document for them in their diary, okay? So if your patient is on fixed dose insulin, so normally your insulin is supposed to take care of the meal they're taking. That is for the bolus insulin, okay? So for example, like the example I gave, in that case, if a patient is on regular insulin 3 units before lunch, that is supposed to take care of the meal, assuming that the blood glucose is going to be within target of 4 to 10. However, if the blood glucose is higher than that before the meal, it means that 3 units is not going to be adequate. They are likely to have a high blood sugar after the meal, higher than what it is already. So we need to give extra insulin, okay, for the high dose of for the high glucose level, okay. So the 3 units you're giving is for the meal they're about to take, but you're going to give extra insulin to bring down that sugar from 16 to within the target range of 4 to 10. So how do you calculate that? So there's a formula. So if the patient is on rapid acting insulin, and rapid acting is examples are Lispro, Aspart, or we have brand names like Novorapid, Humalog, Apidra. So for those ones, you use a constant of 100. You divide 100 by the total daily dose of insulin. And total daily dose of insulin includes the long-acting insulin they're taking. So like for the patient that I put on the poll, the patient was on NPH 4 units, was it 4 units? And was on NPH 6 units and 3 units, 6 units in the morning and 3 units in the evening. And on regular insulin, 3, 3, 3, 3 before breakfast, before lunch, and before supper. So we add up all that insulin, okay, and then you divide 100 by that. If they're on regular insulin, regular is what we also call soluble insulin or short-acting insulin, then the constant is 83. 83 divided by the total daily dose of insulin. So like for the case I presented, the patient was on regular insulin and they were on a total of 18 units of insulin. So we divided 83 by 18, and that gives us 1.46, which we rounded up to 1 to 5. So that means each unit of insulin will lower the blood glucose by 5 millimoles per liter. So that means when the blood glucose is out of target, so if it's between 11 to 15, we need to give 1 extra unit of insulin. If it's between 16 to 20, we need to give 2 extra units of insulin. If it's 21 to 25, we need to give 3 extra units of insulin. I hope that's clear.
Yes, thank you. That was clear. So first, my apologies if I don't mention your name. I don't want to mispronounce it. So the second question was, how do you advise on storage of insulin, especially for those patients who doesn't have a fridge and live in hot area?
Okay, so the storage of insulin was actually addressed last week in the session on insulin therapy. Dr. Legon gave a very nice summary of that. We have options. You can use a pot, earthenware pot, okay, with sand and with charcoal. So I would refer the participant to that presentation, which is likely to be uploaded on the KNH research YouTube channel for more details on that.
Okay, thank you, Tom. So the other question we have is, it says for the blood glucose testing, I recently used 2 different glucometers, same time, same brand. I got 2 different readings, one at 10.2 millimole per liter and another one 12.5 millimole per liter. Which one is correct?
So normally you can get a variation of about 10% between glucose readings from different meters. So that is actually acceptable. So you can take any reading between the two. Yes, there's always some variation, a small variation.
They have been asking about the target, but these questions actually came in between of the session. We have already addressed them. Target blood glucose level for children. The other is, how accurate are digital glucose testing devices like a watch, digital smartwatches?
That's a very interesting question. I really don't know. I don't have much experience with them, and I have not looked at any research that has been done on them. So I do not want to lie. Maybe I go and do some research on that and find out how accurate they are. I have not used them before. I don't know if anyone on the panel has used those digital testing watches before. Yeah, we will find out and get back to you in the next session.
Yeah. So the other question is, what is the cutoff age that includes or classifies a patient to be managed as a child?
So who is a child, in other words? Okay, thank you for that.
Yeah.
For us as pediatricians, and let me say endocrinologists, in our clinic, we see patients up to 24 years of age, yeah? But the definition of a child or youth, I would say youth is defined as up to 24 years. Adolescent is up to 18 years. So we see even up to children up to 18 years. Yeah.
Yeah, thank you for that. So there is a question that says, kindly repeat the name of hepatomegaly syndrome in diabetes. I think they want to ask about the Morex syndrome. The name is Morex syndrome, but if you want, yeah.
Yeah, it's called Morex syndrome. So basically it's a child who has poorly controlled diabetes. The sugars have been high. So what happens is they end up with a lot of sugar being stored in the liver, and then they end up with the steatosis, hepatic steatosis and hepatomegaly. So these patients usually are stunted, okay? The classic features you'll find is that the child has diabetes, of course. They are stunted, they have a hepatomegaly, and they usually have a hypertriglyceridemia.
Yes, thank you. So there is also another question. Great presentation. Kindly clarify for me the following question. How many snacks of DM patients should take, like in a day? How many snacks should they take, and how do you recommend the type of snack they are taking?
Thank you for that. That's a very good question. And actually, we are having a session on nutrition next week on Tuesday. So I would like us to reserve that question for then, so that we will discuss it in more detail, because it also varies with the individual patient. Yeah.
Yes, this is also somehow a similar question in patients with LADA, late onset diabetes of adults. Do they also take normal balanced diet as the rest of the family member? So,
yes, they should take a normal, healthy, balanced diet together with the family members. Yes.
okay. So there is another one question. Most of pediatric patients are missed in facilities by the time they are diagnosed with advanced diabetes. So what implementation should be done, or what preventive measures should be done to impact the loss of those children from the follow-up?
Actually, thank you for that question. That's a good question. So for type 1 diabetes, it's very rare for a child to have had diabetes for long without being picked, because they usually present acutely with diabetic ketoacidosis. And normally you'll find that maybe they've had a history for about 2 weeks. Most of the time it's about 2 weeks of polyuria, polydipsia, which, the parents did not know that it was a significant thing. Yeah? So most of them will present acutely. But for patients with type 2 diabetes, now those are the ones who will have diabetes for long without knowing they have diabetes. And by the time they are diagnosed, they already have complications. So in terms of improving diagnosis, I think it's just about creating awareness to the community, okay, on the signs and symptoms of diabetes, and also creating awareness to health workers like we are doing here, because sometimes these patients come and are misdiagnosed to have other conditions in our facilities until they present later with complications like DKA. Thank you.
Thank you. So there is a question on sick day. We'll have another class on sick day, so I will skip this question. DK management also, it has been discussed last time, so we can get it on the YouTube channel. The other question we have is there is a question with how do you manage patients with HIV, with diabetes, who are immunosuppressed?
Thank you for that. So it depends on what is the cause of the diabetes. Remember that some of the antiretroviral agents cause increased insulin resistance. Okay, so it depends. Does this patient have type 2 diabetes, or is it drug induced? Okay, or is it type 1 diabetes? Because if it's drug induced, if it's due to insulin resistance, then the management is different. Unless it's an acute setting, then we'd need to give, if they have insulin resistance, you'd need to give insulin sensitizers. But if it's type 1 diabetes, the management remains the same, insulin. Yeah, thank you. And then, of course, if it's drug-induced diabetes, then you might want to consider reviewing the therapy, if that is an option, the antiretroviral, the drug that's inducing the diabetes, if that is an option. Of course, if it's not an option, then we would have to just manage the diabetes. Because for drug-induced diabetes, normally once you stop the drug, then usually the diabetes will resolve on its own. Thank you.
Thank you. So I think this will be our last question. It says, my patient developed several wounds on her belly, so she stopped the injectable insulin now, and she's on oral hypoglycemic metformin, 500 milligram BD, and glibenclamide 5 milligram. Her sugar range is below 10. So I don't know what they want to ask, but and the age of the patient is not mentioned. We don't know whether it was the type 1 diabetes or monogenic or type 2. But if you want,
so
this,
yeah, it would be, I think we need more information for that case
yeah.
in terms of the age of the patient and what is the cause of the diabetes. It's difficult to tell without knowing, getting that information. It could be type 2 diabetes.
Yes.
Yeah.
So it says another one question. So it says a machine that does 24-hour reading. I think they are talking about a CGM. I've been using that on my patient and it's quite good. But now the question is the reading are not the same as the glucometer.
So there's usually a lag, about a 15-minute lag in the, thank you for that question. So when you're using a continuous glucose monitor, there's usually a lag. The meter CGM measures the interstitial, okay, glucose. So you'll find that there's a lag of about 15 minutes in the readings between the CGM readings and the finger stick readings. So that is actually normal. But when you're using the CGM, you're able to tell the trends, yeah? Usually it will tell you whether the sugars are going up, whether it's going down, or it's at a stable level. Thank you.
Thank you. There's one question again here. When a child is initially diagnosed, how is the insulin initiated? In a setting where only available is in Mixstart and Axtrapid, which is the best option? We have discussed this one last time when we discussed with Dr. Lekong. Again, we don't advise Mixstart. But if you want to add here also, the floor is yours.
Yes, so like we mentioned before, most of our centers, a number of our centers are supported by CDAC, that's Changing Diabetes in Children, and NPH insulin is available, but we just need to request for it, okay? So we do not recommend pre-mixed insulin, which I've already mentioned also in this presentation, because it's associated with poor glycemic control. And we know poor glycemic control is associated with increased risk of long-term complications. So we would recommend that you request for the right insulin. You can get NPH. If the patient can afford, then you can get Glargine or Lantus. But NPH and regular insulin are available in our facilities. We just request for them and start the patients on the basal bolus insulin. Yes, thank you.
Yes, thank you. So there are some questions on decay. We have been discussing decay yesterday about transition and also the management of decay. So you can just look at it. There's one question. During my normal routine at work, I have encountered 3 siblings with type 1 DM. What can explain this one?
Thank you. That's an interesting question. So when Dr. Phoebe did the introduction to diabetes and etiology, remember that we said that there's a genetic element, even for type 1 diabetes, and then we have the environmental triggers. So there are several possibilities for these 3 siblings, which maybe we need more information. It could be autoimmune, or it could be a genetic monogenic form of diabetes. So those are now the kind of patients that you need to refer for further investigation and who probably even require genetic testing because they could be having a monogenic form of diabetes. Thank you.
Thank you. Last question. Great presentation. Kids above 13 years are treated and admitted in adult medical ward, and a lot about their psychology is missed. What is your take in this?
Yes, thank you for that. That is very true. And it's something that we are struggling with, even for us we are trying to see how we can actually just totally separate adolescents, provide adolescent services separately for all children, all pediatric patients, so that we don't lump them together with the adults and possibly also not lump them together with the very young children because they require special attention. And I think if you're in a position to just initiate that in your facility, whereby you just set up an adolescent ward for them, for the outpatients, if you can have just a youth clinic or adolescent clinic where they can be followed up separately, I think that will really, really go a long way because that is one gap that we really need to address. Thank you.
Thank you. I think we have used most of the time. If you have another question, we'll address in the subsequent class because we're going to have another classes. Thank you all the participants. We have more than 1.2K participants. And if you need to add or if you need to conclude with the last, you can take the floor.
Okay, so yeah, I think my parting shot is let's just review our our structures, our systems, see how we can improve supplies for medications, especially now that we're talking about premixed insulin. Let's engage the people who are supporting us, because I know many of our facilities have organizations that are supporting us with free supplies. Let's engage them so that they can actually supply the right kind of insulin for our patients, so that we can provide them the best chance in life, so that they can actually have a normal life without having to deal with those long-term complications by the time they get to 18 years of age. Thank you very much.
Thank you so much, Doctor. So thank you very much for all participants. Have a good night.
Good night. Thank you.
Good night.